All right, here we go with our third video. And this one we're going to be talking about potassium, which is in our intracellular, not extracellular. And the extracellular one is when we're talking about all of the edema and water with sodium. Potassium has got a much narrower margin than sodium, 3.5 to 5.5, and you have all kinds of symptoms once we're at 6 and once we're below 3. Regulation of potassium is basically by the kidneys. An easy way to learn this, as soon as you learn that potassium is a positive cation, and it's K with the kidney. So we know it's regulated by the kidney. Easy way to remember. Primarily major role in conducting nerve impulses, maintaining electrical excitability of muscle. The heart's a muscle, so remember that. Regulating acid-base balance. Renal excretion increased by aldosterone. Excretion also increased by most diuretics. Potassium-sparing diuretics are the exception. Other than that, we lose a lot of potassium through diuretics. Influenced by extracellular pH, which we talked about last week a little bit, alkalosis, potassium uptake is increased. Acidosis, it leaves the cell. And most of those obstructive oxygen, where we're holding the oxygen in and we can't breathe out the CO2, so they're very, very short of breath, we're losing potassium because that's the acidotic level. And also to note that insulin has a profound effect on potassium. What does it do? Well, insulin, aldosterone, epinephrine, and alkalosis. If you can remember the subsets here, I'm going to say it again. Insulin, aldosterone, epinephrine, and an alkalotic state. They facilitate the shift of potassium into the cell. Wouldn't that make sense? Because we said in respiratory acidosis, it's out of the cell. Insulin deficiency, aldosterone deficiency, acidosis, cell lysis, when you're breaking up cells. Wouldn't that make sense if we have potassium out of the cell? Because we know it's supposed to be inside. So if we're in a state of, like, say, chemotherapy, where we're actually putting toxins into the body to break up those cells, wouldn't the potassium be driven higher? Yes, most definitely. So any cell lysis, strenuous exercise facilitate the shift of potassium out of the cells. So when we talk about diabetic ketoacidosis, can lead to a coma and death, because we can have potassium depletion out of all of the cells. So that is the distinct knowledge base of what insulin does with potassium and for potassium. Potassium maintained by the sodium-potassium pump, a predominant ICF ion, meaning intracellular fluid. Potassium moves from the extracellular fluid to the intracellular fluid with insulin. It moves from the ICF with exercise, trauma, and acidosis with extracellular fluid. Potassium can change and alter excitability in muscles, neurons, pancreatic cells. Potassium is removed by the kidney. Again, just know that the association with potassium is KK with the kidney. And potassium levels with renal conditions, what do you think? If you've got a kidney problem, and we know that potassium is regulated by the kidney, if they're in renal failure or a problem with the kidney, we're probably going to have a problem with the potassium level. Think K again with kidney. High potassium levels can damage the kidney. So if we've got a lot of cell breakdown, high levels of potassium, because it's falling out of the cells into the blood, that can damage the kidney. And again, potassium balance is regulated by the kidney, by aldosterone, which is sodium in water, and insulin secretion, and also by changes in pH. So hyperkalemia, let's look at that for a minute. That would be, remember our level is 3.5 to 5.5. So hyperkalemia, too much potassium in the blood, would be above 5.5. Manifestations, weak muscles, especially the legs, irritability, abdominal cramping, irregular pulse early on, and then EKG changes. Atrial fib or atrial flutter, things like that. Cardiac arrest can come in late stages of hyperkalemia. So again, what's happening? We've got increased potassium intake It's a shift from the ICF to the ECF. It's on the outside of the cell, or decreased renal excretion. Hyperkalemia is actually rare because of efficient renal excretion, unless we have a renal problem. I'm going to talk to you about my dad here. Ongoing problems. That's why I'm probably not going to be at school tomorrow. And that his potassium level came back at 6, and he was going into renal failure. He was extremely weak, could no longer stand. He was having atrial fibrillation. That's what was going on last week when it started. Atrial flutter, atrial fibrillation. So he was, if they had not stopped it, he would have gone into a cardiac arrest. Caused by increased intake, a shift from the potassium from the ICF to the ECF, decreased renal excretion, insulin deficiency. In his case, it's cell trauma because he is now diagnosed with lymphoma. And along with that cancer cell, it's breaking up other cells, which is pulling potassium out of the cell. So how do we manage hyperkalemia? We're going to eliminate the potassium, both oral and parenterally. We're not going to give them potassium. We're going to give them IV insulin because remember, insulin will move potassium into the cell. They need to be on a cardiac monitor because they could be throwing arrhythmias. We need to improve the potassium elimination. So if we've got a problem with the kidney, what are we going to do? We're going to dialyze them. What's dialysis? Dialysis, again, my dad went through this yesterday, dialysis, where we're going to tell them we're going to put all the blood in this dialysate. So they're going to put a special line in, usually it's a subclavian or jugular when it's just for a 1 or 2 time procedure. It's not something that they have to be on for the rest of their life. And we're going to take all the blood out, put it through the machine, and through the dialysate, we're going to clean it up and put brand new clean blood back in. So it's like a dishwasher. We're going to clean it up. Diuretics, we're going to pull that potassium off. A KX-Lite enema. And what is that? It's a resin that exchanges with potassium at the gut level, increasing fluids, and it dilutes potassium in the blood. We're going to increase fluids, infuse insulin and glucose, calcium gluconate. I already talked about the potassium exchange resin. It can be given orally or as an enema to treat hyperkalemia. If acidotic, a very good way to move potassium back into the cell is to infuse sodium bicarb. And yes, he had that too. They were infusing sodium bicarb by the IV. Causes of cardiac standstill: excessive rapid delivery of potassium, excessive use of salt substitutes. You look on the salt substitute, what are they substituting? It's kind of like when they took all the fat out of low-fat things in the 1980s, they put a bunch of sugar in it. So, we all need to go back to the real deal and just have little bits of it. But in a salt substitute, if any of you have parents that are on medications for the heart, the last thing they should be using is a salt substitute. A lot of them will be on low sodium diets, so they go to a salt substitute because they want that salt. Well, they're basically putting potassium on things, and they can become hyperkalemic. So, the FDA, I don't know why they ever approved it. We have people all the time that get in trouble with potassium because of salt substitutes. Renal failure, the heart can stop. Uncontrolled diabetes, massive cell destruction. Again, if the cells are being lysed or broken down, potassium's coming out into the blood. Transfusion of old blood, severe tissue trauma, and untreated Addison's disease. Okay. Hypokalemia. So now we looked at what happens with too much. Let's look at what happens with too little. It's most commonly seen with the diuretic, a thiazide or a loop diuretic, because they're diuresing, so we're pulling all this fluid off, and they can have a low potassium level. Again, it'll be less than 3.5. It's less common. Excessive insulin, if we've given them too much, because remember what we said, if there's too much insulin, it's driving it into the cell. So now we have hypokalemia. We don't have enough. Alkalosis. Adverse effects are on the skeletal muscle, smooth muscle, blood pressure in the heart. Hypokalemia increases the risk for hypertension and stroke, and because it causes cardiac dysrhythmias, which will throw clots. Again, less than 3.5. The causes, now it's shifted from the extracellular to the intracellular fluid. Abnormal losses, it's much like sodium, where we've got NG tubes, diarrhea, vomiting is draining out of the body. Elevated aldosterone, we can lose lose potassium because aldosterone holds on to sodium. Metabolic alkalosis, what are the symptoms? Fatigue, muscle weakness, weak irregular pulse, or arrhythmias. Almost any disease entity can result in fluid shifts. That's why we need to be aware of this as a nurse. Cushing's disease or hypertension, sodium is retained, potassium is lost. Elevated aldosterone is real loss. It facilitates potassium out of the cell. Metabolic alkalosis is a relative loss. If we can fix that balance, it's not out of the body. It's just metabolically we're having a problem. We can put it back into the cell. So what are we going to do? We don't have enough. We're going to give it. They're going to have to take it orally. There's pills you can give with KCl or oral potassium levels. Diet high in potassium, which bananas, there's a lot of foods that are high in potassium that we will give them lists of. Oral route, check the lab and the kidney function. IV route, we got to check the lab, make sure the patient's voiding at least 30 cc's an hour before adding potassium to an IV, because too much potassium can hurt the kidney, and given a stable IV site. Orally is the best way to get potassium, as it's absorbed the best. Again, if we have renal function a problem where we can't give it orally. Average urinary output, we want about 60 cc's an hour. Okay. And then I'm going to start with this one for the third video.